Good morning. I'd like to call the meeting of the Senate Health and Human Services Committee to order. It is Thursday, February 20th, 2025, and we do have a quorum present. We have had a little bit of technical difficulty, so we're trying to make sure that the people on the Zoom can hear and see the video, and I'm being told that they can, so we will get started. Senator Kunesh has the first bill on the agenda, Senate File 942. Welcome to the committee, Senator Kunesh, and I believe you have an author's amendment.
I do, the A2, Madam Chair.
Okay, Senator Mann moves the A2 amendment.
So moved, Madam Chair.
Members, all those in favor, please signify by saying aye. Aye. Any opposed? The A2 amendment is adopted.
Thank you. So members, in front of you, you have Senate File 942, which has to do with student attendance and the response of child welfare. The issue that we have in Minnesota is that Minnesota law currently requires local child welfare agencies to implement a traditional child protection response for screened-in child protection reports of education neglect. And right now, education neglect is defined as 7 unexcused absences for children under the age of 12. A traditional child protection response is often mismatched response to address the underlying needs commonly associated with attendance concerns. A traditional child protection response can look like providing an outdated list of referrals to the family with a threat of court involvement if they don't find a way to get their child to school. This is really not a very meaningful intervention for long-term solutions. We know that the barriers commonly at the root of attendance concerns are things like housing instability, transportation barriers, lack of reliable child care, cultural and language differences, unmet mental health and or medical needs of the child or family members, financial stress, lack of trust and relationships with the school, and many other unmet needs. So in other words, school attendance is often less an issue of parental neglect, but rather an issue of societal neglect, where our systems are failing to support children and their families. We can do better, and we must do better, and we can improve those student attendance in Minnesota by implementing responses that are less punitive at the very first, and then seek to address the actual barriers that the child and the family are experiencing that get in the way of getting to school. This summer we had a study group, a legislative study group, and it was established to study the issues related to student attendance and truancy. And so this bill addresses many of those issues that we came up with recommendations. So the bill that is in front of you will allow local welfare agencies to implement a child welfare response versus a traditional child protection response in reports of ed neglect cases where no safety concerns exist. This change will allow local welfare agencies to utilize community-based providers, family resource centers, or county attorney's offices as a diversionary response. And if the family does not engage in this diversionary response, then a traditional child protection response can be initiated. Those services really must be culturally and linguistically appropriate to be effective. And the funding is requested in this bill to help local welfare agencies implement that diversionary child welfare response, like a pilot program, something like that, and that must include program evaluation to demonstrate program effectiveness so that more programs can be implemented statewide. And with that, I have 2 fabulous testifiers, and to my left is Dr. Nimbabe, excuse me if I mispronounce that, and you will hear some excellent responses from her.
Thank you. Would you like to have Dr. Vera testify first? Then?
Yes, please.
Okay. Please state your name for the record and begin your testimony.
Dr. Vera Ndumbe. School attendance is less often an issue of parental neglect, but rather an issue of societal neglect, said Senator Kunesh. It is an honor to be here today. Olmsted County, alongside a reputable local agency, Family Service Rochester, decided to divert the blame of educational concerns from parents to the society by connecting families to concrete support through case management. The challenge is those concrete supports are limited. Olmsted County recognizes that when what impedes positive educational outcomes for families is not a willful negligence, it is housing challenges, untreated mental health, food insecurities, transportation, inadequate communications between school and families, which includes cultural barriers or language barriers, and lack of appropriate medical care. Olmsted County, alongside Family Service Rochester, through its vision of creating a vibrant community, decided to embrace the community-led response, which is less intrusive to families, dismantle the power of punishment, demonstrate deeper understanding of our demographic landscape, partner alongside families to identify concrete support and foster one of the strongest partnerships I've ever seen with our local schools. Families are more likely to receive services from a local agency than from child protection. An evaluation report completed by 2021 by a fellow from Foster America shows that children who received services from PACE program between 2010 and 2019 reduced their short-term re-entry rate by 16%, either through case management or through assessment, and long-term re-entry rate by 7%. Furthermore, in that same report, Olmsted County avoided a cost of $2 million because the average cost of serving a child through child protection is between $5,000 to $8,000, which is significantly higher than a community-led response such as PACE, which is between $2,000 to $3,000. Senators, families will continue to experience positive educational outcomes because of individuals like you. It is an honor to be here, and thank you for your time.
Thank you very much. Now we have Michelle Miller, who is on Zoom. If you can please state your name for the record and begin your testimony.
Thank you. Good morning. Thank you for having me today. My name is Michelle Miller, and I serve as the Child and Family Services Manager at Wright County Health and Human Services. One of the important points that Senator Kunesh mentioned is that educational neglect is not an issue of child safety. Therefore, a child protection response is mismatched related to the underlying needs of children and families. Educational neglect is a child welfare concern, which is why Wright County has been addressing attendance issues in a child welfare manner since 2011. As we all know, child protection involvement carries a heavy stigma. Parents are fearful of becoming involved in child protection and have no desire to work with a child protection social worker. So our stance has been, why would we add the barrier of child protection to a family struggling with attendance when they're already experiencing numerous barriers, some of which you've heard already? Over the years, we have found that the biggest challenge is typically related to mental health, whether that be the parent, the child, or both. Couple that with additional challenges that have been mentioned, like food insecurity, transportation, financial issues, trauma, and then you couple that with child protection involvement makes for additional barriers to school attendance. We have also found that parents oftentimes have had a negative school experience themselves due to mental health, trauma, learning difficulties, and then they're carrying that trauma into their child's school experience. And oftentimes the relationship between the family, the parents, the child, and the school has been strained. So what we have found is that by using that child welfare response, we're able to come alongside families, support, and engage the parents to get to that root cause of the attendance concern. We believe this working relationship is so important to develop strategies with families, to help engage their networks and supports, to alleviate the barriers that all three of us have mentioned this morning. And then it allows us to come alongside and offer services and supports. Sometimes those are financial, which helps then set the family and the child up for school success. Over the years, our data has shown that the earlier we can become involved with a family to help strengthen, support, and serve them, the greater success children have at getting to school. Thank you.
Thank you very much. Members, do you have any questions about the bill? Senator Abler.
Well, thank you, Madam Chair, and this makes sense to me. And just I have a question, then I'll offer a thought. So, Senator Kunesh or anybody, do you know how much money you think if you could ask her how much money would you ask for in this bill?
Senator Kunesh.
An unlimited amount. So,
Madam
sorry.
Chair, I get it.
Yeah, that doesn't make sense so early in the morning. We haven't put a number in there, and as the session goes on, and if this bill is under serious consideration, I think then it would be appropriate to sit down and really run the numbers across the state. There are some other bills and legislation that will be moving through different departments and different committees, and when we know that there is a strong interest in that this bill will be moved ahead, then we'll sit down and really do some number crunching.
Right.
And Senator Abler.
Yeah, well, thanks. But I think the two testifiers make a strong point that we have the wrong definition. The softest I'll say all this is that the county is going to be under a lot of pressures from many sources about how to even stay in business. We had quite a bit of testimony last night that you weren't at, but in the Human Services Committee, just in general, and even the costs from the African American Preservation Act is a burden on them that they weren't expecting. I mean, I'm a huge fan of that, as you know. So if we just have to find a way to make this all fit in there. And
right.
So just advice to you. I think maybe there's a way to change the definition and at least get them not chasing the wrong fix to the situation, so they're not burdened with making this a whole high-scale thing. And so I'm happy to work with you on that if you want, but I think it would be sensible this year to work on the redefinition and then let the county deal with it and the schools deal with it as they would within their resources, as they would ordinarily do their business. So anyway, thank you, Madam Chair.
Senator Kunesh.
Yeah, I think you're on the right track there. Definitely that definition needs to be edited and amended as we have here, but it doesn't really make a lot, it won't make all the difference in the world if we just change that definition and don't create opportunity for some of the wraparound services that are going to address those issues that are contributing to the truancy. If we can, and I'm education finance chair, so we are looking at, transportation, mental health care. We're already alleviating some of the issues around hunger by the universal lunches, those sort of things. But we can change words here and there, but unless we really are going to get serious about this, it is going to take an investment and provide some of those wraparound services. So thank you.
Anything else? And then this bill does need to go to judiciary, so it will have to go through the process and come back, in terms of the funding, we would have to address that later in session. So, we will have conversations about appropriations later in session.
Well, just Madam Chair,
Senator Abler.
I think I would just strongly encourage you to talk to the advocates for this bill, which it makes a lot of sense. At least you don't have to overreact to a case.
Right.
But your desire to get funding for this, I appreciate your optimism.
Thank you so much.
Other questions? Senator Curran.
Thank you, Madam Chair. Senator Kunesh, I was just looking through and just trying to figure out the carve-out or the delineation between under 12 and over 12. Absenteeism, and I guess I haven't seen the detailed reports, I know you're on the education, when the city of Minneapolis, right, one of the, to me, kind of a crazy report that came out that highlighted 46% of their students are attending on a regular basis. But it didn't really highlight a great breakdown. Is it exclusively over 12 that the problem we're trying to solve? Or at 46%, I assume, of Minneapolis public schools, I assume it's in all grade levels, elementary through, K through 12. Why the differentiation in this bill that carves out under 12 from in a different manner?
Senator Kunesh.
Oh, pardon me.
That's okay.
And maybe our folks from DCYF, if they want to come up and talk about this as well. That age 12, the response to the under age 12 and the over age 12 is important because those that are over age 12, there are different circumstances that tend to keep them from coming to school. Oftentimes, it is they're needed at home to watch younger children. They might need to help their parents with some of the language barrier issues. So the issues above age 12 are different than some of the issues. And those are, that pre-K through 12 are those really formative years where the students really need to be in school and be getting the services and the education and those wraparound services that they need. And so we're focusing on the under 12 as the focal point for this bill specifically.
Okay.
Senator Coran.
And thank you, Senator Kunesh, because I do believe, if we can't get them there, you mentioned the food program, it doesn't matter because they're not there. And it's foundational to their success completely. One of the things that I always thought was unique was, I think 6 years ago when they did the Lucy Laney story, if you remember that, the Lucy Laney Elementary, the Love Them First documentary. One of the things that they did, which was the wraparound services are true, and we've got enough to smother an elephant in this state. But we don't have one person who cares enough to help that one child. And so what I haven't heard is kind of going after that root cause, because it's going to be the community. No government service. We're smothering everybody with more government services, more government services. We already have truancy laws and all those things in place today. Mm-hmm. But that model really would have changed. That model would change everything. And I haven't heard anybody that's in education or that model have an approach or take that approach, because what they did is Maury Fresselbein convinced their staff they were going to go out summers to find one person who gives a heck about each child. Hopefully it was mom, if not dad, if not somebody in the community, to prepare them, one, to get to school, and then two, for any of those other wraparound services. None of this, it doesn't sound like it does any of that. And so I would love to, as you move forward, that we could somehow break this broken educational model. And, this is coming from a conservative about school choice and all those things. Choice doesn't matter if there's no one there to exercise it for each of those children, and especially those children with the greatest disparities. And so I would love to have a conversation about this. We've already had truancy laws. It hasn't worked. How do we get to a place where 46% of the kids aren't attending on a regular basis? And even a rough definition of what's a regular basis. Mm-hmm. Two days a week is more regular than none. And so and that's a failure of the school system. Right? How did they let it happen? And in conjunction with County Human Services and what the county truancy laws that we have today. So I think it's good. We have to highlight it. But I'm not sure it's getting to the actual solution. Because if we still don't take the work and to find one person who cares, none of it's going to matter. And so, and I think it didn't happen because it threatens the current school system in bringing in. I'd hire 5 grandmas in that community who give a hoot, that can have a conversation, and I think that's what they motivated in Lucy Laney's story. We need to see more of that, and I know it threatens the existing educational system of the teacher licensure, all that garbage. We gotta break into that in that model, because it's going to be the community and a community school that saves those children. Because the only ones can have a dialogue. And so, and I know I was on the other side of truancy of it. May not have been a great student in high school. I know what it looks like, but you know what convinced me is having the threat of a parent or somebody on the other side that got you to school.
Yeah.
We don't appear to have any of those things today. So how do we get to that one person? So I would love to work with you to figure out baking that in, because what we have, and this is more of what we already have, and I don't think it's getting to the root cause. So I'd still love to address how we take a different model within the school to start and eliminate it there before we even have to have more truancy action. So thank you.
Senator Kunesh, I think your bill does address some of the truancy definitions in order to get us closer to what Senator Cran is getting at. Senator Kunesh, do you have a response?
Just that it does take the community to bring our children into the places where they are going to find the success that we are looking for. And I know as a teacher of 25 years, we very intentionally, at least the school district and the schools that I was in, very intentionally tried to reach out to these students. But when you have limited time and limited dollars, and those that don't always have the skill to do that, and that's what this bill is trying to do, and with the work of the counties as well, who have the responsibility towards addressing truancy issues.
Members, are there any other questions or comments? Well, thank you, Senator Kunesh. I think that this change in the definition is a start, and obviously, along with that, the county, as a county testimony we've received in letters, has indicated that they see this as a good way to approach these situations in a better manner, and if we have the supportive resources around and available, that this will make a positive impact for kids. So,
Thank you.
Members, we will vote now on the bill. Let's see, Senator Mann moves that Senate File 942 as amended be recommended to pass and be referred to the Committee on Judiciary. All those in favor, please signify by saying aye. Aye. Any opposed? The Senate File 942 as amended does pass and is referred to the Committee on Judiciary.
Thank you.
Thank you.
Thank you. Next, we have a presentation from Commissioner Cunningham. Members, we had some bills that related to maternal health, and we thought it would be a good opportunity to get some additional background and thoughts from the Commissioner of Health, and her expertise in this area of maternal health is really a valuable resource for our state. So welcome to the committee, Commissioner Cunningham, and I will let you get your slides called up.
Chair Wicklund, members of the committee, thank you.
Commissioner Cunningham, please.
Thank you for having us here today to talk about this important issue. I know you have several bills in this space. I am joined at the table with our Assistant Legislative Director, Autumn Bond, and Dr. Mira Sheff, one of our subject matter experts in maternal and child health. As you've often heard before, Minnesota is often ranked as one of the healthiest states in the country and one of the best states to raise a family, with strong economic indicators and quality of life. While Minnesota has lower rates of pregnancy-related death compared to the U.S. overall, maternal health disparities in Minnesota tell a different story, one where not all Minnesotans experience the same outcomes. Maternal health includes the health of the woman before, during, and after pregnancy, and it covers a range of topics. It includes mental health, within that substance use disorders, chronic diseases, and access to care in terms of the services individuals receive as prenatal care. All of these topics have a significant impact on maternal health. To achieve healthy outcomes in pregnancy, women need access to basic needs, food, shelter, prenatal care, and to live in a safe environment. When we look at data from 2017 to 2019, Black pregnant women in Minnesota are 2.3 times more likely to die of pregnancy or childbirth-related causes compared to white pregnant women. The American Indian maternal mortality rate is approximately 4 times higher than white pregnant women, and 40% of maternal deaths occur in greater Minnesota. Community-informed solutions are needed to address potential opportunities and gaps and to connect individuals to birthing services and resources to support optimal health outcomes. Next slide, please. Now, when we think about maternal health, we must also appreciate the interconnectedness between the mother's health and the health of the infant. Many of the same health disparities that mothers face impact infants. Babies of mothers who do not get prenatal care are more likely to be born low birth rate and to die within their first year of life. Minnesota's infant mortality rate is 2 times greater among infants born to Black and American Indian parents than among non-Hispanic white parents. And prematurity or a birth before 37 weeks is the leading cause of infant mortality in Minnesota, and Black, American Indian, and multiracial parents have the highest rates of preterm births. Access to prenatal care not only provides significant benefits to the pregnant person, it also confers significant benefits to the infant. Now, many factors impact the health of Minnesota mothers. Many of these factors are what we refer to commonly as the social determinants of health. In 2022, 18% of American Indian mothers and 8% of US-born Black mothers reported either they or their husband or partner went to jail, compared to 1% of the overall Minnesota population. Now, certainly incarceration often leads to worse mental health. It leads to significant economic hardship, finding a job, securing housing after release. And many times we find that those individuals who end up being incarcerated actually have worse health even before they are incarcerated. When we think about food security, food insecurity is worse for households with incomes below the poverty line, for single mothers, for Black and Hispanic households. You cannot be healthy during pregnancy without nutritious food. Hence, programs like the WIC program, which provides food to pregnant people, are very important. Transportation is another social determinant of health. In 2022, 24% of Black and 25% of American Indian parents reported that lack of reliable transportation kept them from medical appointments, meetings, work, or from getting things done needed for daily living. We talk about women not getting the care they need during pregnancy, and sometimes that's because they don't have the transportation to get it. Of course, low income intersects with all of these. It's another social determinant of health. It tracks with low quality education, the quality of employment, and whether you receive benefits during employment. And certainly if you cannot pay your rent or your bills or the copay for your doctor's appointment, that leads to significant stress. Stress leads to high blood pressure, which is a leading cause. Uncontrolled high blood pressure is a leading cause of maternal morbidity as well. And the finest social determinant that I'd like to discuss here is homelessness. In 2022, 11% of Black and 12% of American Indian parents reported they were homeless or had to sleep outside in a car or in a shelter. All of those social determinants of health affect downstream health outcomes. And when we look at access to care, during pregnancy and delivery. It's not consistent across Minnesota counties. 36 out of 87 counties in Minnesota do not have a birthing hospital. Hospital closures and provider shortages lead to unequal access to maternity care in rural areas and among communities of color. We know in areas without birthing hospitals, people have to travel long distances to receive care or give birth, often driving up to 2 hours or more for their care. And the further the distance is a pregnant person must travel to receive maternity care, the greater risk of receiving inadequate prenatal care. Data from Minnesota birth records shows that babies of mothers who do not receive prenatal care are 3 times more likely to be born low birth weight and 5 times more likely to die than those mothers who do get care. Minnesota has received 2 Health Resources and Services Administration, HRSA Health Innovation Grants focused on improving maternal health outcomes and addressing these barriers of care. The first is the Rural Maternity and Obstetrics Management Strategies Program, which funds maternal health networks to improve access to care and health outcomes in rural communities. The second is the Families First Rural Maternity Health Collaborative, which aims to increase access to care, enhance care coordination among network partners, and improve maternal and neonatal outcomes in northern Minnesota. Additionally, a partnership within Northwest Minnesota with the Indian Health Service, health systems, and counties is improving and expanding regional obstetric care services, including increasing access to specialty high-risk obstetric care and implementing evidence-based protocols to improve emergency response to hypertension crises and preterm labor. With that as an introduction, I want to walk you all through some programs that we have to improve maternal health and disparities within Minnesota. They include the Pregnancy Risk Assessment Monitoring System, the Maternal Mortality Review Committee, our Innovations for Maternal Health Outcomes in Minnesota project, also known as IMOM, and the Transforming Maternal Health Model. So PRAMS is the short name, the acronym for the Pregnancy Risk Assessment Monitoring System. Minnesota PRAMS is a surveillance project between MDH and CDC to collect information on maternal behaviors and experiences before, during, and shortly after a woman's pregnancy. Minnesota is one of 47 states participating in this project since 2002. PRAMS provides data on mothers and babies that is not available from other sources. The goal of PRAMS is to improve the health of mothers and babies in Minnesota by reducing the risk of adverse birth outcomes like low birth weight, preterm birth, and as well as infant and maternal mortality and morbidity. Though PRAMS is a project with CDC, they only provide a fraction of the funding to states to implement those activities. CDC provides $175,000 per year, which covers only about 36% of the total program cost of $485,000 per year. This is a minimal investment to better understand racial health disparities and the true impact of postpartum depression and other issues impacting Minnesota mothers. It is important to note that currently all participating PRAMS states have lost access to data collection systems that are maintained by the CDC due to federal administration executive orders. This has paused all PRAMS survey activity as staff are unable to collect or manage any data needed for the program. 2024 data collection was not yet complete, and data collection for 2025, due to start in April, is on hold indefinitely. Let me share a bit of what we know thanks to our previous PRAMS efforts. We know that mental health conditions during pregnancy and in the postpartum period are generally underdiagnosed, not treated, and underreported. Postpartum depression is a common but serious mood disorder that affects mothers after their baby is born. Mothers may experience profound feelings of sadness, anxiety, and fatigue that can hinder their ability to successfully engage in everyday responsibilities, such as self-care or caregiving for others. This graph shows that 32% of Minnesota mothers in 2022 reported that they needed mental health services after their baby was born. And the highest need was among American Indian and U.S.-born Black mothers. Though U.S.-born Black and American Indian mothers reported the highest need for mental health services, they were least likely to receive those services compared to white mothers in the state. We also recognize that systemic racism is a root cause for creating and continuing to create barriers to accessing quality care before, during, and after pregnancy and delivery. U.S.-born Black and American Indian mothers reported more experiences of discrimination during their pregnancy than other groups. This slide shows that 42% of Black mothers and 42% of American Indian mothers, respectively, report that they were treated badly during their pregnancy as part of their care. 33% of U.S.-born Black mothers and 24% of Hispanic mothers and 23% of American Indian mothers reported being emotionally upset because of racial discrimination 12 months before their baby was born. Many pregnant individuals, especially from communities of color, seek support from doulas and/or midwives specifically to help bridge this access gap to provide critical continued support and to improve outcomes for the whole family. Of the mothers who reported feeling upset because of racial discrimination before a baby was born, 29% experienced postpartum depression. And 22% reported not receiving a postpartum checkup because of how they were treated in their care experience while they were pregnant. The percentage of low-income respondents who self-reported postpartum depression was also 2 times higher compared to high-income respondents. Substance use clearly continues to be a problem across the nation and in Minnesota, and it is a risk factor for maternal morbidity and mortality. Maternal morbidity is any short or long-term health problems from pregnancy and giving birth, such as high blood pressure or infections. Severe maternal morbidity is any severe outcome from pregnancy and giving birth that can result in significant health consequences, such as a heart attack, a stroke, hemorrhage, respiratory distress. When we look at individuals who report substance use versus no substance use, individuals who had substance use disorder documented at time of delivery are more than 3 times as likely to have at least one severe maternal morbidity condition, which, as I said, could be anything from a cardiovascular condition to a stroke to hemorrhage. And when we look at the rate of opioid use disorder at the time of delivery in Minnesota from 2019 to 2023, it was 61.4 per 10,000 delivery hospitalizations. The rate of substance use disorder at time of delivery hospitalization in Minnesota has decreased by 11.5%, yet it is still an ongoing issue. The northern regions in Minnesota had the highest rates of opioid use disorder compared to the rest of the state. Certainly more support is needed to address substance use disorders and mental health services through interventions such as virtual visit capabilities, increasing the number of waivered providers, improving access to treatment, and implementing harm reduction and overdose prevention practices statewide. Unfortunately, a number of these conditions can lead to maternal deaths. And so we have a maternal mortality review committee. That review process is the highest standard for state-based data on maternal mortality. Our committee that looks at the deaths of individuals who were pregnant includes many specialties and perspectives to gain understanding of what happened from many different lenses. It includes the voice of our communities, especially from communities most impacted by maternal health disparities in our state, It looks at where systems connect and where they don't connect, which helps us to expose gaps, especially those related to socioeconomic status or mother's ability to meet basic needs for food, safety, and housing. The committee examines all Minnesota maternal deaths to identify and reduce preventable contributors and causes, including the effects of access to care. When mothers cannot access care, they miss the opportunity to find and manage problems when they are still minor, when they are still early in the condition progression. Certainly, there is a strong link between prenatal care and birth outcomes, which means when someone doesn't receive that care, they are more likely to have poor outcomes around delivery and postpartum. We look at standardization of care. Within our healthcare system, unfortunately, not everyone receives the same standard of care, but if more mothers receive the recommended standard of care, outcomes can improve. For example, all pregnant women should be screened for violence, interpersonal violence, including firearms in the home. Discrimination. Patients, as we have already discussed, who have experienced discrimination are less likely to seek care. That's what we discussed when we saw that subsequently people did not follow up as often when they had had bad experience of care during their pregnancy. So if we can reduce discrimination in care, we can also improve outcomes. We also look at structural racism in terms of, are there ways in which systems or institutions are built to perpetuate racism, policies in health systems, for example, screening tests and other screens that are not done universally for everyone in care. And then mental health conditions and substance use disorders, as we've discussed, that can lead to death from both intentional and unintentional overdose. So the review process involves 5 steps. We identify the deaths of Minnesota residents. We select and collect their health records and review records about the death. We develop an abstract and conduct interviews with those involved, and we write a de-identifiable story about the death. We review the story about the death, and as we do, the committee makes decisions on several key questions, specifically, if she had not been pregnant, would she have died? And then we disseminate the data for action. The committee makes recommendations for changes at multiple levels, and by comprehensively reviewing every death, making recommendations for action, and acting on those recommendations, the work of the Maternal Mortality Review committees can eliminate preventable pregnancy-related deaths, reduce maternal morbidity, and improve population health for women of reproductive age. Again, just to share some, give some picture into the funding, the Maternal Mortality Review Committee is heavily dependent on federal funding via a 5-year grant from the CDC. We have some additional state funding from this work, but CDC provides close to $500,000 per year for this work. The state provides an additional $163,000 annually. The total cost of this work is $658,000 per year. Again, these dollars are ultimately invested to help us better understand where the gaps are, to address concerns, to make clear and actionable recommendation. No one wants pregnant and postpartum mothers to die. No one wants to leave an infant without their parent. So pregnancy-related deaths are one of the most extreme examples of bad outcomes. They are the tip of the iceberg of what is happening in Minnesota, happening to Minnesota mothers. And by understanding what happens in the worst cases, the committee makes recommendations to improve care for all people. Let's look at some of the data more closely to look at the committee's findings. While Black mothers and American Indian mothers are a small proportion of the birthing population, they are disproportionately represented among pregnancy-associated deaths. Pregnancy-associated death is a death during pregnancy or within 1 year of the end of pregnancy, irrespective of cause. This table shows that Black mothers make up 13% of women who give birth, but they make up more than 20% of the deaths, a more than 2-fold increase. American Indian women are about 1.7% of pregnant women, and they make up 12% of the deaths, a more than 7-fold increase. And we have unpublished data to be released this spring from 2020 to 2021 that illustrates that these disparities not only persist, but have widened, in particular for American Indian women. In 2019, 74% of pregnancy-associated deaths were of metro residing residents. Overall, the metro represents more births and deaths, in part because there's a larger population compared to the rest of the state. When you look over the 3-year span of 2017 to 2019, 60% of pregnancy-associated deaths were residents of the metro. Though the metro experiences more births, several greater Minnesota regions have higher proportions of deaths as compared to their proportions of births. This next table shows the leading causes of death, again from the 2017 to 2019 report. Injury, including suicide and homicide, is at the top of the list, with suicide often captured in injury. Mental health conditions that are listed below often contribute to those suicides that we see captured in injury, but also there are a number of conditions such as cancer or infection postpartum that contribute to maternal mortality, and there were some causes that could not be identified. With the release of their reports, they release a number of recommendations to prevent maternal deaths. Let me walk you all through those quite briefly. The recommendations are to support statewide improvements for women who have substance use disorders or mental health conditions, again referring to the table as a leading cause of death for pregnant people, to develop standardization of referral networks to improve the postpartum period by ensuring that women have access to a care team no later than 3 weeks postpartum, so to get people back into care, to again address bias in systems that may perpetuate disparities for women, and to acknowledge the impact of historical trauma and racism on women, to fund community-led networks and support systems to provide culturally informed care to meet women's needs, and very importantly, to listen to and support women. Additional recommendations from the 2019 reviewed pregnancy-associated deaths focuses on improving access to and availability of services throughout the pregnancy and postpartum stages. These additional recommendations also emphasize the critical need for seamless care for individuals with a substance use condition and or mental health condition during this pivotal period of their lives. The next program that I want to highlight is the Innovations for Maternal Health Outcomes in Minnesota project, or what we refer to as iMom. This program was created in 2022 to align and strengthen the implementation of innovative, data-driven, community-informed, and supported perinatal health programs to improve outcomes for communities experiencing the highest rates of disparities. With the support of community leaders via a perinatal subcommittee of the Maternal and Child Health Advisory Task Force, the iMom goals and activities include innovative programming, the data capacity, implementing statewide quality improvement and care initiatives, and building a skilled perinatal health workforce to reduce perinatal morbidity and mortality. Now, iMom has a number of recommendations. The subcommittee has worked to create a strategic plan on perinatal health and aligned efforts across the state, county, and community level. There have been 10 reports with over 300 recommendations were reviewed to come to the 13 iMom recommendations that you see before you. This was a process of adapting, editing, prioritization with this committee, a process that also contained community feedback, and the recommendations are soon to be revised and published. The action teams that are putting these together are, again, a diverse group of people with expertise across, people with lived experience across the provider community, and involve community-based organizations and providers. So I'll leave it to you all to look at the 13 recommendations, but certainly lifting up education and training, a diverse workforce, looking again at healthcare system policies, culturally responsive practices, and certainly addressing substance use disorder and the care for people who are incarcerated. And then partners at DHS submitted a proposal which was funded. We are one of 15 state Medicaid agencies selected in January of this year to participate in transforming the maternal health model. MDH is part of that core team. This model supports innovative approaches to improving maternal health care services for pregnant people and postpartum people. The goals are seen there to reduce disparities, to improve outcomes, and to reduce costs. Core elements to do this include increasing access to midwifery workforce and birth centers, to cover doulas and grow perinatal community health worker workforces, to implement the Alliance for Innovation on Maternal Health Patient Safety Bundles and achieve birthing-friendly hospital designations, home monitoring of diabetes and hypertension as important chronic diseases to address to improve the health of pregnant people, and to provide risk assessment, referral, and follow-up coverage from perinatal depression, anxiety, substance use disorder, and health-related social needs. There's an evaluation component to this model, and there are clear indicators that the team at DHS has identified with their partners. It will look at indicators such as the risk of low-risk cesarean section, the rate of low-risk cesarean section, severe maternal morbidity, the incidence of low birth weight infants, changes in the experience of care for those who are pregnant, giving birth, or postpartum, and changes in Medicaid and Children's Health Insurance Program expenditures. So that is a broad overview of our work, of the importance to address maternal health and morbidity in Minnesota. Certainly some take-homes are that Black and American Indian women in Minnesota face significantly higher risks of maternal mortality, highlighting deep inequities in healthcare access and quality. And certainly if we want Minnesota to truly be the best place to raise a family, we must address these disparities, ensure that every mother and baby has an equal chance at a healthy start. Thank you for your time. Again, I have Dr. Sheff and her colleague, Dr. McGraw, is sitting behind me as subject matter experts, and we are happy to take any questions.
Great. Thank you very much for the comprehensive review. Just one quick question. Have you thought about, you mentioned that the Maternal Mortality Review Committee work was federally funded, and have you heard anything about your CDC grant money for that particular program and how you would address it if that money is not available? Commissioner Cunningham?
Thank you, Chair Wickland. Certainly we are concerned about all of the monies that fund public health from the federal government side. When I was here before you all last, I mentioned that 50% of our budget is federally funded. Clearly, core programs in maternal health are federally funded at high percentages. We have not currently at this point heard of any cuts that have happened as of today to those programs, but certainly there is great anxiety about potential cuts on the horizon.
Thank you. Senator Abler.
Well, thank you, and I'm sorry I missed the presentation. I'm pretty familiar with what you're trying to do and just some of the challenges in the system. As we move a system from birth, pregnancy a disease, to actually something that happens for quite a long time in history, we seem to get stuck with the practicality of how we deliver our health care. And I just had quite a long chat on the way in this morning with a doctor who was running a birth center and finds nothing but barriers. And so just as you work on your solutions here, I'm happy to talk to you offline, but I'm going to suggest to you that everything you're talking about is a great thing to say, but in practicality it's not happening, particularly for the populations you're seeking to help. The Medicaid Minnesota care population, which is our duty here, hardly the commercial sector at all. They do what they want, especially the self-insureds. It's not working. And so birth centers, because of poor reimbursement rates and because of competition from hospitals and others, are actually going out of business, not going in business. And I'm suggesting to you it's a chronic problem. Maybe it's a DHS funding thing or whatever, but if this is truly a priority for you, and I applaud the priority, then let's make it a priority, let's make it work, and I'm happy to be that person. But I wouldn't have brought it up. I just talked to the guy this morning, and there was a birth center someplace in greater Minnesota that closed, which does not do what you want. You want more birth centers, more home births, more doulas, more people to reach into those families and make a difference. And so I guess it's a two-sided thing. It's a little, maybe you don't even know what I've just told you, but you need to know that, and then we need to actually, if we care, unnecessary birth complications cost a lot of money. And never mind the pain on the family if you create a birth injury that could have been avoided, if you have, all the regular issues that go into the prenatal and bad habits of people that don't even know that, still to argue that alcohol is okay and all that. So anyway, just to encourage you in that, and I cheer you on, and if I can be useful in that process, I will. But I'm just pointing out to you that for all the meetings and that you have about stuff, it has to translate into an application. In the FQHCs and all across there where they struggle to stay open. I think that leadership could come from you because of your passion and commitment. So thank you very much.
Commissioner Cunningham, I don't know if you can give any more details. The transforming maternal health model is specifically addressing Medicaid, and it does mention improving access to birth centers, and MDH is playing a role in that core team. So I don't know if you want to elaborate more on what that core team role will mean and how you might convey some of this information.
Thank you, Chair Wicklund. I will start, and then I'll ask my colleagues if they had anything to add. I will just say, both through what we're seeing in the data, but also anecdotally, we do know that many people do want to deliver their babies at a birth center. Sometimes the choice is because that is the provider who's providing access in their region, given what we just saw about the closure of obstetric care service lines across greater Minnesota in particular. Sometimes it's, right here in the metro where communities of color don't feel that they are respected when they come into traditional care settings and hospitals, and so have turned to, again, centers that more align culturally with their values, as well as that they have better experiences of care. So I have been aware of the trend, Senator Abler, to which you speak. And I am someone like you who is concerned that when these recommendations come out, that we figure out mechanisms with you all to increase accountability for the outcomes. And I don't have information, but I will turn to my colleagues in case they do and offer them an opportunity to contribute to this conversation. But the Transforming Maternal Health model certainly is going to evaluate practices, the depth of incentivizing or hold people accountable. I'd have to turn over to DHS as the main payer. I don't know if at this stage, since this is an early model, whether that is baked in, but certainly, Senator Abler, to your point, it is great to come out with recommendations, but there has to be uptake and accountability for the uptake of those recommendations, which often come from you all and other sort of partners like plans and others. I don't know if, Dr. Sheff, you have any other comments, and if not, we've gone.
No, I don't. No additional comments.
Senator Abler, is that anything else?
No, you're going to run out of time, but I'm just suggesting to you, this is a marvelous thing. And so I don't think it matters what your background is. You want to have the experience of giving a birth. We've been through 6, and I've talked to dozens of midwives and over the years, and we got them credentialed when I was a freshman. And I think that if you're with these brilliant people you're working with, if they can just kind of look and see what we have, and you go like, it's not working. Why do we need to disincentivize C-sections. We need to disincentivize behaviors by the plans and by the hospitals where we pay them. And these birth centers push people to much better outcomes. But it's hard to have one. In fact, they more fail than succeed. And those are perfect places for everybody to go to in their neighborhood and be comfortable and and it's better when it's less, then everybody wins. And so I'm just encouraging you to go beyond some words on paper to how can it really work? Anyway, I don't want to spend all our time, but this has been a topic for all my 26 years. And we try to get better at it, and people come forward with a nice report, and here we go. And meanwhile, we have less birth centers, more pressure to go to the hospital, more pressure to do traditional things, and have outcomes that are not great, and experiences that aren't great for all women. So thank you, Madam Chair.
Senator Kupek.
Thank you, Madam Chair. Just one quick question. Slide 16. I know you just crashed. I'm sorry to bring back the slide here. I was just trying on slide 16. I was just trying to figure out what the numbers were on the map, and clearly I can see northern Minnesota. The numbers are higher, but I just was what exactly are those numbers? Because it can't be a percentage, and there's 0.9s, and I'm just curious what those numbers actually mean.
I believe it's an incidence rate, but I will let Dr. Sheff answer.
It is a rate.
Doctor, can you state your name for the record before
Sorry.
you?
Yes, it's Dr. Mira, it's M as in Mary, I-R-A, and then Sheff, S as in Sam, H-E, F as in Frank, F as in Frank.
Thank you. And go ahead and answer the question.
It is a rate. So it's it's a rate that you expect per 10,000 delivery hospitalizations.
Okay. Thank you, Madam Chair. Just clear that up. Thanks.
Okay, thank you. Senator Bolden.
Thank you, Madam Chair. Thank you for this presentation. I have two questions. The first is about slide 5, which talks about there are currently today 36 out of 87 counties that don't have a birthing hospital. And you touched on this a little bit. My sense is this is in part it has changed over time because of closures and consolidations, as we have seen, particularly in greater Minnesota. I'm wondering, and I don't need an exact number now, but I'm wondering if you could just talk a little bit about, is this a trend? How has this changed, and how has this changed in the last 2, 5, or 10 years?
Commissioner Cunningham.
Chair Wickland, Senator Bolden, thank you for that question. Clearly, we have seen a lot of hospital closure. You know, when I just talk about in general the hospital landscape, 70% of the hospitals that have closed since the pandemic, since the last 5+ years have been in rural areas, have been in greater Minnesota. Clearly, hospitals have also, when they haven't closed, they have reduced service lines, and they have made decisions, and I'd have to leave it, and I'll ask my team to sort of expand on any insight into sort of the variables that go into the drivers of those closures. Certainly, their financial, implications, but there may be other considerations that have made many hospitals decide to close off their obstetric services. And we have seen greater closures, Senator Bolden, I think and other members of the committee, we have seen greater closures in recent times. To get more data, I'd have to get back to you. I don't know if you have any.
Senator Bolden.
Thank you for that. I appreciate that. My next question, and you touched on this in relation to the PRAMS program and data that you now are not able to get because of an executive order. We are seeing the Trump administration and their attack on everything diversity, equity, and inclusion. And I'm wondering how that has the potential to affect this work. How the Minnesota Department of Health used to work with the federal government in terms of gathering and analyzing data to study maternal health. Are you seeing that change? How do you expect that to change, and how will that impact Minnesotans?
Commissioner Cunningham.
Chair Wickland, Senator Bolden, again, thank you for the question. We remain in a great deal of uncertainty. Nothing has come down sort of the pike. Clearly, there are relationships that we have with the federal government. One, we have partnerships around technical assistance. Clearly, maternal across the country are wrestling with when we have worse outcomes than even some lower resource countries, and that should not be the case for Americans. So certainly, technical assistance networks to work together and brainstorm to get at new solutions to move the needle. Clearly, the funding implication, as we went through the slides, clearly we put that in deliberately because the bulk of these monies for much of this work, whether it's PRAMS, the Maternal Mortality Review Committee, comes from our federal grants, and we would not be able to do that work or extend that work as some of the bills coming up here will suggest. We would not be able to extend it if we don't have those resources. It is highly concerning. No impacts to date, but again, we anticipate potential impacts. There's a lot of talk about the Prevention and Public Health Fund. A lot of our work, whether it's women's health or chronic conditions that contribute to maternal mortality, are within those buckets. And so all of these things are interrelated, and the impacts of reductions in funding, lack of networks and shared information and technical assistance would be significant.
Senator Bolden? No. Any other questions? Otherwise, we will move to bills that do relate to supporting mothers. Thank you very much for coming to the committee today and for your expertise, and we will get back to you with other questions if we have them. Thank you.
Thank you, Chair. Welcome. We welcome that. Thank you, committee.
Next, we will move to Senator Maye Quade, Senate File 1113. Welcome to the committee, Senator Maye Quade, and I believe you have an author's amendment, the A2.
Yes, Madam Chair, Senate File 1113.
Senator Abler moves the A2 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Senator Maye Quade.
Thank you, Madam Chair. Members, good morning. Before you is Senate File 1113, which is a bill to codify medical assistance coverage of birth services provided at home. While demand for care hasn't changed, access to labor and delivery hospitals has decreased significantly across Minnesota, as you've seen, and the cost of care is high to maintain in less populated regions of the state, meaning that the impact of lack of access is hitting greater Minnesota the hardest. Access can also be restrictive in some regions where pregnant patients are forced to drive over an hour to their prenatal care appointments. In rural communities with limited or inconsistent access to perinatal care or prenatal care, home birth providers offer critical care to fill gaps. This bill would allow home birth providers to serve more Medicaid clients who choose to give birth in their home and improve reimbursement rates for those providing those services. Thank you so much for your time, and I will let my testifiers talk more about the importance of this bill.
Thank you, and we have two testifiers who are on Zoom today. First, we have Rosa Osterreich, and I apologize if I have mispronounced your name, but if you can please state your name for the record and begin your testimony.
Hello, Chair Wickland and members. For the record, my name is Rosa Osterreich. I live in Ely, Minnesota, and I have a rural home birth practice. I am the president of the Minnesota Coalition of Certified Professional Midwives, the largest licensed midwife organization in Minnesota. I also serve on the board of the National Association of Certified Professional Midwives of Minnesota. I have been a midwife for 20 years. I've caught over 3,500 babies out of hospital. I am an expert in out-of-hospital birth. I am here to testify in support of Senate File 1113 SF 1113. Within my experience in hospitals, birth centers, and in my clients' homes, I have seen the truth about access to maternal health care in Minnesota. The reality is Minnesota is failing pregnant people in Minnesota. It is causing long-term harm and health complications for both mother and baby. Hospital labor and delivery units have been closing all around the state, but it is hurting greater Minnesota the hardest. In my area alone, Ely, Minnesota, Grand Marais, Minnesota, International Falls, Minnesota, delivery units have all closed. Too many mothers and babies do not have access to the care they need. I received 2 calls from women this year scared for their lives and their babies who are forced to give birth in the back of their cars, trying to seek care trying to drive to their nearest provider who is up to 2.5 hours away from their home. 4.5 years ago, I made the conscious decision to move to Ely, Minnesota, a perinatal desert, so I could make the 2+ hour drive to provide care and comfort to expecting mothers in greater Minnesota, because no one should give birth alone. Right now, the only people who have access to home births are people with private insurance plans and families who can afford to pay out of pocket for home birth services. I have at times had to make the decision of whether I provide care to Medicaid clients at no and receive no reimbursement, or for them to birth without a healthcare provider at home. As midwives, we cannot afford to take Medicaid clients without additional compensation. Midwives meet with clients over the course of many months to provide prenatal care, to attend the birth, and conduct postpartum visits. 1 day, 3 days, 7-day support in their home. Under Medicaid, we are only reimbursed $1,380 for all of our work. To put that in perspective, my private pay clients on average pay me $7,000. This policy will allow for home birth providers to access 70% of what hospital bill for facility fees. This reimbursement will help us cover the cost of supplies, our time and labor, and care that is provided over the course of many months. Paying home birth providers more to provide care for low-risk pregnancies will cost Minnesota taxpayers less. The exorbitant price of inpatient hospital stays and administrative overhead costs is reduced significantly when care is provided in the home. Minnesota can and should take better care of pregnant women and their newborns. This is a cost-effective strategy that will help families in rural Minnesota access the care they need and have the best possible start of life. We need to do better, because we can do better. I urge you to please support Senate File 1113, SF 1113, to support the perinatal workforce that provides quality, personalized care to newborns and mothers in Minnesota.
Thank you very much. Next, we have Sasha Barif, and again, I apologize if I'm mispronouncing your last name. If you could please unmute and state your name for the record and begin your testimony.
Thank you. Hello, Terwick Linden members. For the record, my name is Sasha Barif. I live in Roseville, Minnesota, and I'm a member of the Minnesota Council of Certified Professional Midwives. I have about 10 years of midwifery experience. I'm a certified professional midwife, a licensed midwife, and I'm a board certified lactation consultant as well. I'm here to testify in support of Senate File 1113 because it improves access to maternal health care and increases compensation for home birth midwives in Minnesota. This policy will allow for home birth providers to access compensation for supplies used at a birth, the time it takes to set up, travel, and provide months of prenatal and postpartum care for the clients using Medicaid. Over 30% of all births in Minnesota are covered by Medicaid, and most of those births happen in a hospital, which is the most expensive option for pregnant people. Hospitals and birth centers are closing, not because there aren't pregnant people in Minnesota, but because the professional fees are so low. For example, I lost my job at Willow Birth Center in Minneapolis, a busy birth center, at the end of the year. Lack of investment in maternity care has resulted in the entire field piecemealing our billing and funding sources to stay afloat. We need to raise the professional fee for midwives so we can pay our bills. We can't afford to continue to provide care for free or at reduced costs, but we have continued to do so because we believe that everybody deserves access to care, to quality care, personalized perinatal care, and have the choice of how they give birth. Birth work is one of the oldest and underfunded professions in history. Traditional healing practices and sacred ceremonies were passed down through generations, which have been lost due to the increased medicalization of low-risk pregnancies and childbirth. As institutions and the government continue to get more involved in the birthing process, education requirements, licensure, supplies, and supply costs have risen for our providers. We cannot afford to survive off the global fee of $1,300 per birth, $1,380 to be exact, and we as home birth providers cannot bill for facility fees to offset these low reimbursement rates. If we break these fees down, every birth, for example, is accompanied by a midwife and a midwife's assistant for safety reasons. If the starting fee is approximately $1,300, from which the average $500 assisting fee is deducted right off the bat, leaving the midwife with $800 per client. At this rate, the total fee of $800 translates to approximately $11.43 to $13.33 per hour, based off the conservatively average 60 to 70 hours that are spent providing care to each client per episode of care, which is not accounting for the necessary expenses like office space, equipment maintenance, travel, continuing education, and licensing fees. These policies will not fix the maternal health crisis in Minnesota. We know that a large investment is needed to help the field catch up to other medical providers, but this policy is a tangible strategy that will help us stay in business and to stay afloat so that we can continue to provide life-saving care to expecting mothers in Minnesota. Where the state of Minnesota chooses to invest its money is a clear indicator of our values and priorities. Please choose to invest in care of pregnant women and pregnant people and their newborns this session. Thank you for your consideration. I urge you to please support Senate File 1113 today.
Thank you very much for your testimony. Members, do you have any questions? Senator Abler?
To the bill. This is exactly the direction to go in, precisely. It's the target where we want to put our effort. And frankly, if a department is doing anything resembling a dynamic fiscal note, putting money into this will absolutely save probably a factor of 2 at least on just the costs of the birth. And I don't know how to calculate how many bad things will not happen to the mother in terms of infections and to the child in terms of some of the consequences where they're just allowed to be in their home and relax, and when time comes, there we go, and less intervention. So thank you for this. I'm happy to be a co-author.
Any other questions? Senator Liskey.
Thank you, Madam Chair. Madam Chair, Senator Maye Quade, thanks for bringing this forward. As a individual who lives in a very rural community that is now farther away from birthing centers than it was previously, with Mayo closing the one in New Prague, I can understand the need for this. I see what happens. You know, I had parents that reached out and said, hey, now we have to move. Now we're going to Maye Quade to see the same provider that we had. That's an hour, not a 15-minute drive. So it makes a massive difference. And so this gives options for mothers to pick something that can mean a lot to them. So I appreciate it. Thank you.
Any other questions or comments? Senator Maye Quade, any final thought?
No, Madam Chair, I really appreciate the discussion, and I'm really grateful that the department was here to kind of preview this topic too. And I don't even know if we would need dynamic fiscal notes for this, because if it's just offering, these services for people who are already pregnant, we might be able to just see the savings right away. So hopefully we'll see. But I appreciate you giving me time today to talk about this bill, and to my testifiers in the Birth Justice Collaborative and to Nolan for all their work to get this together.
Thank you. It does seem like it's very timely to hear this right after we hear the presentation. We know there's a lot of work to be done in this area, and this would be a specific way to move forward to assist. This bill, Senate File 1113 as amended, will be laid over for possible inclusion. And now, Senator Maye Quade, you have Senate File 1167. Senator Maye Quade.
Thank you, Madam Chair. And I have an oral amendment, if I could offer that first.
Sure. You were offering it as an oral author's amendment. Can you tell us what amendment?
Yes. On line 1.6, after the word conduct, insert an annual. On line 1.7, delete studies and insert study.
Can I have, Senate Counsel, can you please state the amendment as we should consider it?
Thank you, Madam Chair. The amendment would read, Senator Maye Quade moves to amend Senate File 1167, page 1, line 6, after conduct, insert in annual, page 1, line 7, delete studies and insert study.
Members, are you all clear on the change? Senator Bolden, would you move the oral amendment as was stated?
So moved, Madam Chair.
All those in favor of the oral amendment as moved by Senator Bolden, please signify by saying aye. Aye. Any opposed? The oral amendment is adopted. Senator Maye Quade.
Thank you, Madam Chair, members. So Senate File 1167 is very simple. It's probably one of the shortest bills we'll have all year, but it's one of the most consequential. And it will require our maternal death studies to be conducted annually instead of, right now it just says they may conduct them. The United States has one of the worst, if not the worst, maternal mortality and morbidity rates in the world, and you heard a little bit about that. Our last maternal mortality study was done in 2017 to 2019, and it found that there were 8.9 maternal deaths per 100,000 Minnesotans. For our Black population, that was 26.7%, and for our Indigenous population, that was 12%, even though they only make up 13% and 1.7% of the population total. And so, if we're going to tackle this problem and really reduce the number of preventable deaths or eliminate the number of preventable maternal deaths in Minnesota, we need good data. And so we're going to just have this happen annually so that the commissioner can report out the trends, the patterns, and the solutions to address the maternal mortality crisis here in our state. My remarks were longer than the bill.
And I don't see any testifiers. You don't have any testifiers for this one. Members, do you have any questions? Senator Liskey.
Thank you, Madam Chair. Madam Chair, I believe I'm working on an amendment. We're waiting to hear from it, but I can offer the one that we do have, and I do have with me. It's the A1, and then we'll talk about the edits that are working their way towards us, I believe.
Senator Liskey offers the A1 amendment. If you could start to talk about it as it's being passed out.
So the A1 amendment, after listening to the testimony from the commissioner and all the presentations and things, my concern was, after reading through this, it's a great bill. I think what you're trying to do is a solid, valid argument. I just want to include the fetal portion of the argument as well, so maternal and fetal deaths. So all I'm adding to the bill, once it's organized correctly, I'm not changing the must back to may. I'm changing that back to I'm keeping with what you've already done. I just want to add the word and fetal into the discussion of the studies. So that way we can have the information not only on the mothers, but also the children that are involved.
Senator Maye Quade. So this is a delete everything, so it would not incorporate the language that we just adopted, correct? Senator Liskey.
Thank you, Madam Chair. So again, I'm trying to keep everything of what she was trying to change. We're working on trying to make it all happen at the same time, and so that's what we're attempting. So the delete all, yes, currently we'll do that, but I believe council's helping me fix that issue.
Okay. Senator Maye Quade, do you have a response?
Madam Chair, can I just have a second to read this?
Yes.
Thank you. Madam Chair.
Senator Maye Quade.
Thank you, Madam Chair. So I guess I'm just reading through this, and I was trying to, Senator Liskey, I'm trying to understand the purpose of this, and I'm not a doctor or a lawyer, but I'm probably further from being a doctor than a lawyer, but what is it that you're looking for in fetal deaths? And the reason I'll say that, and I might need some parameters. So for example, if I had a miscarriage at 12 weeks, would the commissioner be required to study the reason for the miscarriage? I guess I'm just trying to understand the parameters and what the commissioner and the study would be saying.
Senator Liskey.
Thank you, Madam Chair. Madam Chair, Senator Maye Quade, I guess what I'm trying to do is have the same concept, but as what you're trying to do, right? You're having the maternal deaths, you're trying to figure out what's causing those. I want to have the same reasons for the fetal deaths that are occurring. I want to have an understanding of why they're occurring and have a better understanding of those types of things. So, in an instance where the mother passes away, we have to understand, well, was it caused by an illness? Was it caused by something else, right? I think that's what we're trying to get to. I want to know the same reasons behind why the fetal death might occur in a same instance. Does that make sense?
Senator Maye Quade.
Thank you, Madam Chair. And Senator Liskey, I mean, it does, except, 1 in 4 pregnancies ends in miscarriage, and the reasons aren't always known. And so I guess I'm imagining, I'm just trying to, are we tracking then miscarriages, and I'm not really clear on how we're going to be conducting the study, and are people required then to turn over the remnants of their miscarriage so that they can be studied and I guess I'm not totally understanding how this would be conducted, but I'm not a doctor, and maybe the doctor or the nurse on the committee could explain a little bit more.
Senator Liskey.
Thank you, Madam Chair. No, I don't believe that's what we would have any intent on. Again, it's just a study. So the question becomes, why did it happen? If the answer is known, we would have that. Otherwise, the answer would be unknown, right? So it wouldn't be necessarily a guaranteed answer. But if, let's say, I believe the intent of some of this is to find if there's a social determinant of health that's causing the mortality of the mother, and I would want to see if that same thing is causing a mortality of the fetus.
Senator Mann, did you have a
Thank you, Madam Chair. So we're already required to turn in information of all fetal deaths above 20 weeks, which is we should do and we are doing. But I agree the way this is written, this amendment is written, if I had a miscarriage at 5 weeks and my doctor knew about it, we would have to potentially dig into my toilet and dig out the remnants of my miscarriage to turn it in to study why it happened. When 1 in 4 pregnancies end this way, the way this is written is just not manageable or realistic, members.
Senator Maye Quade.
Thank you, Madam Chair, and thank you, Senator Mann, for putting words out loud that I was already thinking in my head, and it is because we already do study fetal death at past 20 weeks, and so all I'm thinking of is, I guess, week 4 to week 19. That's really early in pregnancy, and the reasons are myriad, and sometimes they're related to the person who's pregnant, sometimes it's related to the genetics of the embryo or the developing fetus, sometimes it's related to weather. I mean, there are myriad reasons, not all of them knowable, and I guess I'm not too comfortable with digging into the miscarriages of Minnesotans in order to study fetal deaths in this particular way. Yeah, I'm really uncomfortable with the idea of studying Minnesotans' miscarriages, which is what this would end up being.
Senator Abler.
Oh, thanks. And it's an interesting conversation. We just had a big talk about disparities in birth and so on. And this committee is going to be here for a few weeks yet. I think it's a worthy discussion. And I don't know if the Department of Health can comment in brief, like what they do on post-20 week. I don't think anybody is looking to, we've had 3, with 2 miscarriages and 1 stillborn on top of our 6 kids. And a good number of them wind up as a miscarriage, and I don't think anybody's trying to get at that. But I do think that there's ways that fetuses can die due to all kinds of reasons, and I'm just curious what we do collect so we can know what, it would just be nice to know. I see the Minnesota birth system, as you heard me comment before, as quite a failure on behalf of particularly the people that are at risk and the Medicaid and Minnesota care populations that we serve. And so can I don't know if they're equipped to handle that question, but I think it's a worthy one that we should know. So do you know Senator Maye Quade, or are they here today? Did they all leave already, or did they?
Senator Maye Quade.
Thank you, Madam Chair, and I apologize, Senator Abler. Right as you said, the part of your question, I was looking down at this. Can you repeat that, what the question was?
Senator Abler.
Yeah, well, I'm curious. So people say they already collect data about 20-week, fetal deaths. I'm interested in what they do collect about that, and is it sufficient? Is it by ethnicity? Is it by income? Is it by where it happened? Is it by home birth, birth centers, hospitals? And so if that's already collected, then that's good news, and then the amendment doesn't matter. But it might be that there's something we want to know, especially if we're trying to get after this whole big new direction in success in birthing that the department is after. So do you have any idea, or is the Department of Health here to comment about that? And I don't know that they knew this was coming, but I see a person walking.
Oh, I have the form right here. Yeah.
Senator Maye Quade or Ms. Baum?
Feel free, yeah.
I'm not sure that you have the information today with you because we were focused on maternal health, and we were focused on this bill, which is relating to maternal studies, maternal death studies. Ms. Baum, did you have a comment?
Chair and members of the committee, I actually just have part of my team here, and we were discussing that we don't have the full detail or scope of the response that you're looking for, Senator Abler. So if possible, we would prefer to get back to you with those details.
Senator,
I have it.
This bill is being laid over.
Okay, thank you.
Senator Maye Quade.
Thank you, Madam Chair. I do have that. It's called a worksheet for creating a fetal death report. It is found on the Minnesota Department of Health website. And it's, fetal death or stillbirth or the death of a fetus before or during delivery. And it's registered at 20 or more weeks. And so this can happen, unlike other deaths, which are usually registered with funeral directors. It can happen in or on the way to the hospital, or can be registered by hospital staff. So the worksheet specifically will include, it'll allow you to name your child if you so choose, and provide the date of birth, because when about 20 weeks is when you're delivering, right? It's stillborn, comfort care, that kind of stuff. And then it will denote if they're singleton, twins, triplets, or other. The sex, the place, and of birth, and the attendant's name, where the birth happened. And then it allows the gestational parent and the second parent, if applicable, and then can give some information about, did they participate in the WIC program? Did you smoke? And then there's some demographic information that are optional. So it is a worksheet that is available. There's guidelines on there, and then there's cause of fetal death if they know it. So initiating cause, so it could be maternal conditions, obstetric or pregnancy complication, fetal anomaly, fetal injury, fetal infection, and then it asks about maternal conditions, so preeclampsia, diabetes, anemia, a previous preterm birth, any conditions that the gestational carrier could have, so HIV, listeria, syphilis, or any other STIs, and then some additional morbidity pieces, so it can track if there was a maternal transfusion or a cord prolapse, seizure during labor, ruptured uterus, so on and so forth. So it's pretty extensive, and I'm sure painful for the families who are filling it out, but this is, I would say, comprehensive and existing. Anything that would be added then, I think, to Senator Liskey's amendment would be trying to study miscarriages, spontaneous, or I'm assuming induced, prior to 20 weeks. And I don't know if that is the road we want to go down of surveilling people's miscarriages prior to 20 weeks.
Senator Liskey.
Thank you, Madam Chair. Senator Maye Quade, obviously that was not my intent of the bill. I wasn't looking to enter into the miscarriage discussion. It was more of to try and find a link that might be occurring during the maternal death, right? So when in providership, right, when I'm in classes, none of my classes are just called maternal health. They're called maternal and infant health. They're called maternal and infant. There's never a separation, right? Because when we're taking care of the mother, we're also taking care of the child, and vice versa, right? The goal is we're taking care of both most of the time during pregnancy. We're taking care of them both together right after pregnancy. And so I think the purpose of your bill is valid, right? I never disputed that. In fact, I support what you're trying to do. I just wanted to link the two together because I think that when we find something that happens to the infant, a lot of times there's something happening with the mother and vice versa, which is why in the form you're reading, those questions are there. And I want to get the study that you're trying to put together to include the description of what happened with the infant at the same time. Does that make sense?
Senator Maye Quade.
Thank you, Madam Chair. Yes, it does make sense what you're saying, but I think you're actually putting two things together that are already separate and for good reason. So the leading cause of death for pregnant people is murder, right? And that is often intimate partner violence. But then if you look at the fetal death studies, the leading cause of death is a fetal anomaly, right? And so those actually aren't linked. And so we are studying fetal deaths pretty intensively, and that's available on our department website. And then we may study maternal death, but that is going to be different because it's hemorrhage, it's infection, it's lack of access to care, right? And so I actually think it's really important that we're treating maternal deaths as something to be studied, and we also are studying fetal deaths, but they're separate because when there's a fetal demise, it's not always a maternal death. And if they are linked together, that's a very different scenario that we're talking about: injury, suicide, homicide. Very, very rarely do a fetus and a mother have the same condition happening, right? Preeclampsia happens to the pregnant person, or a genetic anomaly happens to the fetus. So I think it's important that we keep the maternal death study as is and the fetal death study as it is, because now we will have both. It's just now we're going to make sure we study it annually.
Senator Liskey.
Thank you, Madam Chair. So again, like I said, I'm not trying to derail your thing. In fact, I intend to pull this amendment back just because I wanted to have the discussion of, I do believe that unfortunately the infant health also is directly related to the maternal health and vice versa. They are a very much coexisting situation happening. Obviously, without a baby, you're not a mom, and without a mom, you're not a baby. So it has to work both ways. And so that's just why I'm trying to link the two together. And it's a discussion I just wanted to have, and I think it's a valid reason why the amendment maybe as it's written is not great, and I support what you're saying. So at this time I will remove the amendment, but I just wanted to bring up the discussion. So thank you.
Senator Liskey withdraws the A1 amendment. Members, any other questions? Senator Mann,
Thank you, Madam Chair. Just a brief comment. First of all, I just wanted to clarify some medical points that were made erroneously today. First, the fetus is not an infant. They're very different things. Two, when something happens to a 5, 6, 7, 8 week, 9-week fetus, that does not mean that something is happening to the mother and that the mother is perfectly healthy. And three, lastly, there is absolutely in medical education, women's health and maternal health, apart from fetal development and fetal health. So it just goes to we have to get away from this idea that once a woman is pregnant, she does not count anymore and she's part of a two. She still counts and her decisions still matter and her health still matters. So the idea that once she becomes pregnant, everything else disappears is crazy, and we have to stop thinking that way. Thank you.
thank you. Senator Utke, Senator Utke.
Thank you, Madam Chair. And this is actually, Senator Maye Quade can address it, but it's actually more for the department. The bill is just saying that they have to conduct this study and report back. We just got a presentation from the department half hour ago or whatever. They had a lot of data in there referencing more maternal deaths. Mm-hmm. My data shows that they haven't done a study or a report since 2019. Was that report that old? And why hasn't the department updated that information in the last 5 years? I mean, they talked about it a lot now, but supposedly they're working with quite old data.
Senator Maye Quade.
Thank you, Madam Chair. And I want to say two things. One, it's very possible that it's happening right now because we looked at 2017 to 2019. But two, I would imagine because the statute says they may do it, not they must. And so I think putting in the requirement to do it, but unless the department wants to speak to it more, but it's the point of the bill.
Thank you.
Madam Chair?
Welcome, and please, can you state your name for the record and begin? your
Yeah, I'm Dr.
answer?
Rachel McGraw. In my capacity as the Women's Health Consultant at the Minnesota Department of Health, I coordinate and facilitate the Maternal Mortality Review Committee. We are currently doing reviews. The review process is lengthy. It takes some time to go through all 5 of the steps that the commissioner identified, from first identifying the case, then collecting information about it, writing the story, and then getting it to the review. We do strive to disseminate information regularly, and as the commissioner also shared, we're in the process of writing a report at this time to be released later this spring.
Senator Radke.
Thank you, Madam Chair, and thank you for that. But I guess, we just sat, again, listened to that report, and we assume, I guess, when we get these things, we're talking about current data. So I do like now it says must. You're going to have to update it, and I think that there really should be some sort of a disclaimer that we're working with old materials, and some of those things insinuated stuff pretty current. I think it was a little misleading, but that's all. Thank you.
Senator Utke, I will just make a note that the presentation, the hard copies that we had, it doesn't have the footnote about the year of where the data was collected on these paper slides, but it was on the screen. I mentioned to Anna that, MDH might want to make sure, or when we print things, we want to make sure that we capture all of the information, because it was a notation on the slide, but unfortunately, it isn't showing up on the handout. And we are getting a new one, so we will have that. Anything else, members? Senator Maye Quade?
No, thank you, Madam Chair. I appreciate the discussion and look forward to this being included in either an omnibus or sending it to the floor if you so desire today.
Today, we will be laying Senate File 1167 as amended is laid over. And now you have Senate File 183. And you have an author's amendment?
I do, Madam Chair. The author's amendment just brings the bill into line with what this committee amended it to last year. I don't know why I didn't catch that, so.
Okay. Senator Mann moves the A1 amendment. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. Senator Maye Quade.
Thank you, Madam Chair. Members, before you is Senate File 183, which prohibits health professionals or students or residents participating in a course of instruction, clinical training, or residency program from performing a sensitive exam on an unconscious or anesthetized patient without informed consent. For purposes of this bill, sensitive examination is a pelvic, breast, urogenital, or rectal exam, and included are 2 exceptions to the informed consent requirement in the event informed consent cannot be obtained. If the patient is unconscious and incapable of providing informed consent and the sensitive examination is necessary for diagnostic or treatment purposes. A court-ordered sensitive exam to be performed for purposes of collecting evidence is the other one. With few exceptions, patients under anesthesia or unconscious patients should have the secure knowledge that there will not be sensitive exams happening without their consent. This bill came to me actually from an individual, and after introducing the bill, I learned there are numerous states with the same type of legislation, blue, purple, and red. And so I hope that Minnesota can join those 20 other states with identical laws, and I appreciate the bipartisan support. I think we have one testifier, and I do just want to note that the U of M and the hospital associations have been great partners. They've sent over what their policies are. So this isn't really outside of the policies that we have in the state, but definitely want to make sure it's codified into law.
Thank you. And we have a testifier on Zoom, Molly Montague. If you could please unmute and state your name for the record and begin.
Hi, thank you, Madam Chair, members of the committee. I'm Molly Montague with the Rape, Abuse, and Incest National Network, better known as RAIN. We are the nation's largest anti-sexual violence organization, and we run the National Sexual Assault Hotline. It is actually through the hotline that we learned of the issue being addressed in SF 183 by survivors calling the call having experienced a non-consensual pelvic exam. I'd like to illustrate this with an example. Let's say you go into a hospital for a shoulder surgery, and while you're under anesthesia, students are brought in to practice a rectal, prostate, or gynecological exam on you. You'd probably expect to know that they are going to do that ahead of time. However, someone could conduct a practice, non-medically necessary pelvic exam while you are under for your shoulder surgery, and you wouldn't necessarily know it's happening. While likely uncommon, these practice exams, which are unrelated to the procedure the patient went in for, do happen without the explicit permission of the patient. This is because in Minnesota, there is no law for the students or the physicians to lean on if asked to conduct these educational exams without the patient's consent. Most physicians and students want to build a relationship of communication, trust, and consent with their patients. Requiring patients to give explicit informed consent prior to these educational exams protects future medical professionals and patients. Especially for survivors of sexual assault, waking up from a procedure to find that they were violated elsewhere in their body is extremely re-traumatizing and causes some to avoid future medical care. 26 states have a law requiring explicit informed consent, including Ohio, who passed it just this last year, Missouri, Maryland, and Pennsylvania. The American College of Obstetricians and Gynecologists and the American Medical Association Code of Medical Ethics support informed consent practices for unconscious patient practice exams. This simple policy will give medical students and those who train them the support of the law when seeking consent before educational pelvic exams and ensure that medical interactions are transparent and safe for all patients. As such, I urge the committee to support Senator Maye Quade's SF 183 and ensure that permission is given before these practice exams. Thank you.
Thank you very much. Members, do you have any questions about the bill? Senator Atke.
My only question is, it seems like what we're talking about would probably already fall under the licensing and code of conduct by all the professionals, et cetera, but do we currently have a problem of this? And if so, how big a problem is it?
Senator Maye Quade.
Thank you, Madam Chair. Like I said, this came to me from somebody in the state of Minnesota that this happened to. It is not an epidemic of it happening, but I think the idea is to be sure that there's uniformity throughout the state. I think, I have conversations with the University of Minnesota, the American Medical Association. These are their ethics, it's their policies, but we want to make sure that this is uniform and consistent across the state.
Senator Atke.
Thank you, Madam Chair. And I guess just to reiterate a little bit more, we've got a lot of medical professionals around the table here. Wouldn't that already be in their code of ethics? I mean, does somebody want to dive into that, or is this really needed is what I'm after?
Senator Mann, did you?
Sure. It does happen. It's happening less and less, but it has happened. We have heard stories of this happening, and it's not malicious. It is done for teaching purposes, but they are very sensitive exams, and so to have just a consent before they are done is the least we can do. And again, to have uniformity across the board so everyone's operating under the same guidance is generally important.
Senator Atke. Any other questions, comments? Okay, any final thoughts, Senator Maye Quade?
No, I appreciate the good conversation and hopefully look forward to this very free policy being included in Omnibus.
Thank you. And this bill, Senate File 183, as amended, will be laid over for possible inclusion. And now I would like to see if we can take up Senate File 971, which is the bill we were hearing the other day And we, on Tuesday, the 18th, we were hearing Senate File 971, and we were dealing with the A1 amendment at the time that I laid it over. So we will start at the point of resuming debate on the A1 amendment. Senator Liskey.
Thank you, Madam Chair. Madam Chair, I'm going to withdraw the A1 amendment. Thank you.
Thank you. Senator Liskey withdraws the A1 amendment. Senator Mann.
Thank you, Madam Chair. We do have the A2 or 3, A3.
The A3 amendment is.
Madam Chair?
Members, Senator Abler.
If there's a way to co-author it, I'd like to do that. But anyways, I want to thank Senator Mann for her work.
That I don't know if we have, but Senator Mann moves the A3 amendment. Can you please describe your amendment?
Yes, Madam Chair. So again, we just wanted to make sure that the intent of this bill was clear. This does not provide blanket immunity for people doing bad things to patients. This does not protect criminals. This does not protect people who are willfully violating the law. This is just for honest medical errors which occur regularly. In this case, it was a nurse who grabbed a medication that started with VEC instead of VER and gave that medication instead. Her license was removed. She'll never practice again. She'll never be a nurse again. She's treated thousands of patients, but because of this one mistake, her medical career is over. And we just want to make sure that she doesn't have to go to jail or become a criminal or have a criminal record because of this one mistake. That's it. And so this amendment that Senator Abler worked on makes that very clear, Madam Chair.
Thank you, and I appreciate your work on this. Appreciate also Senator Abler, your work on this. Any members, any comments or questions? Senator Abler?
I just appreciate the clarification. I believed in the idea of the bill, and now it's entirely clear. And I think this is something that should become law, and I will encourage my colleagues across the street to support this. So thank you very much. It's a good idea. Thanks.
So seeing no other discussion about the amendment, we'll take a vote on that. Senator Mann moves the A3 amendment. All those in favor, please signify by saying aye. Aye. Any opposed? The amendment is adopted. And now to your bill, Senator Mann, as amended, we need to send this bill to judiciary. Are there any final comments or thoughts from members?
I'm sure she's been
Senator
such a good
Abler.
author. Is it fair to send her to judiciary? I mean, it seems like a
Sometimes it works out
cruel
that
and
way.
unusual punishment. Thank you.
It's just what you have to do. All right, seeing no further discussion about the bill, Senate File 971, or Senator Mann moves that Senate File 971 as amended be referred to the Committee on Judiciary and Public Safety. All those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail. The Senate File 971 as amended is referred to the Committee on Judiciary and Public Safety. And members, we have reached the end of our agenda, and we are adjourned.